I'm Zavin Sargassem. I'm going to talk about left axis deviation, both the causes, but importantly to understand how it happens. So under normal circumstances, when the heart is structurally normal and the conduction system is working as it should, the axis, the mean electrical axis of the ventricular depolarization is determined by the sum of the vectors, the average of the vectors of both the right and left ventricle depolarizing normally, which is to say thickness-wise from endocardium to epicardium all at the same time. And that usually results, as you can kind of tell by the visual sum of these arrows, of a mean axis that is somewhere between straight down, 90 degrees, and straight to the left, 0 degrees. So what would cause the axis to be abnormally deviated leftward, meaning pointing that way? So I'm going to give you two important categories, and those are inferior myocardial infarctions and left bundle branch blocks or left anterior fascicular blocks. So again, in normal circumstances, in lead 1 you're going to be positive because you're going to be pointing left-ish, and in lead F you're going to be positive because you're going to be pointing down-ish. So let's look at what happens when you have, say, a left anterior fascicular block. So this is the left anterior fascicle and it's broken. So the left ventricle is going to be left to depolarize abnormally and not necessarily thickness-wise and somewhat lengthwise. And that is going to leave the depolarization arrows looking somewhat like this. And as a result, the depolarization is going to be leftwards, sure, but also upwards. So in lead F, which points downwards, you're actually going to have a negative depolarization. In the case of an old inferior myocardial infarction, where instead of a normally depolarizing part of the ventricle here, you just have necrotic or scarred tissue, the conduction system is still working fine. So you're going to have a normal depolarization of the RV and of the normal parts of the LV, but because there's not as many of the downwards and forces, you're going to have a net vector that's going to end up kind of pointing up and to the left. So in lead 1, you're just going to have a positive depolarization. And then lead F, again, F points down, you're depolarizing upwards, you're going to have a negative depolarization. Now the only difference and the way to distinguish an old inferior MI from left anterior fascicular block with a narrow QRS is to actually look at the inferior leads. If the inferior leads have Q waves or QS waves, then it's an old inferior MI, whereas if there is still a little R wave and you have an RS complex, then it's left anterior fascicular block, or if the QRS is wide, it might also be a left bundle branch block. Now, these are the causes of left axis deviation, and you may say I'm omitting an important one, which is left ventricular hypertrophy. Most of us are taught that. But it actually turns out that the mechanism of left axis deviation in patients with left ventricular hypertrophy is actually injury to the left anterior fascicle. And in people with LVH who don't have left anterior fascicular block, the axis is actually not left deviated. Okay, so to summarize, the major causes of significant left axis deviation are either an old inferior MI or left anterior fascicular block or left bundle branch block. If you have inferior Q waves, it's probably an IMI, and if you don't, it's probably left anterior fascicular block. Thanks.